Do you want me to use
the
a microphone?
Oh, I think that's okay.
Okay.
To walk around. And
Yeah, we have like active
So, it should be
right now.
Okay. How much do you guys hire at?
If they're holy shit.
They yell at me to.
Like, are you here?
All right, I'm gonna go see what's
We're 10.
for
I get paid more working women since
wow.
Yeah, we don't get
Yeah.
paid anything, but it's fun. And their
Yeah.
hours are really flexible. So if you're interested, let me know because we're hiring schools.
Yeah.
Whenever the semester finishes out,
So hard to get
I'm
a
gonna
family out
start
here.
figuring it out in January. Why is the minimum wage so small?
Why is it only on
Why
one?
is it 10? They
Yeah.
keeping us.
Yes.
That is not enough to pay my rent. It is just simply not.
My parents pay my rent right now because
Yeah.
I literally can't afford it.
I pay mine, but my mom.
It should be. It normally is. Yes, right.
That's really cool.
Oh, it's
Nice.
this one's
I kinda like it.
top.
Oh, it's part of the microphone.
Yeah.
Oh my
If
gosh,
you
you
get
know
rid of
more
it,
than
you're
I do. Oh, that's okay. I'll let you in here a little bit. Sorry, you're fine. Whether or not I can change it is another question, but.
Learning something.
Yeah.
The next semester.
Come on, one of you must do something.
Oh, guys, last semester. I don't know. It usually ends up power on and it closes out.
Yeah.
Yeah, somebody must have plugged in.
I don't know if I can get it through this.
Good, I just had it, because I turned it off, I didn't.
Yeah, okay, yeah.
So it should do that.
Oh, yeah, sorry, just, yeah, thank you. I can say like.
Yes.
Even if.
Yeah,
Okay,
and
and
then
then still gonna do it.
when we need to switch over this to the other PowerPoint, it's just a different tab.
Okay, sweet. Okay. It's just a different tab.
Yeah,
Okay.
we shouldn't have to mess with this real quick.
Okay,
We should be starting this kind of.
How do they do it though? How do they?
You're okay.
Did I not
So biggie.
The
Clicky?
clicky, it's over here.
I do not know what it is.
That's okay. We'll just stay close.
Yeah.
That's totally fine. Sorry about
No,
that.
that's okay.
Sometimes they're like, you need your own clicky.
Yeah. Oh, this is me. No, it's.
It's okay. It's not a big
Keep an
deal.
eye out.
I tend to be a wanderer.
Yeah.
Oh, that's a table.
That is not ideal.
If you just wanted to like mention, like it's still tied.
Yeah.
If anyone hasn't voted, just vote.
Okay, gotcha. Okay, sweet.
I'm gonna grab another one.
I got you. Okay, thank you.
Like, say, you already have your computer here. Yeah.
Guys, we are gonna go ahead and get started. Happy Wednesday, happy last remote body meeting of the semester, we've made it. That's good news, guys, that's good news. So just a few quick announcements to get through before we go ahead with this general body meeting. So small animal hospital rounds have been happening this week. If you were there yesterday, I hope you enjoyed. We do have it going on tomorrow as well, November 30th from 6:30 to 8. So that is super exciting. This coming Monday, I believe, we have a SAVMA meeting at 5 p.m. If you need any information about that, you can check the group meet, the emails, or speak with Montana or myself. We also have a D&I meeting, the first one of the semester, this coming Wednesday at 7 p.m. So same time as a general body or executive board meeting. I am super pumped about this new opportunity that we have. Versus been working really hard on kind of revamping the old system that we've got, and it's gonna be really cool. So check the email for more details. And then we also have a winter social happening this Sunday. But we don't have all the details ironed out for it quite yet. So just keep your phones on, you keep your group meetings going. And then, let's see. We also are gonna do a little club spotlight here for the Carbon Capture Club. So just in the honor of trying to get you guys more involved in other professions around campus. So you can learn how to implement sustainable practices, research and development of the carbon net negative technologies. I know Ohio State's been pretty big on this the past couple of years. And then participate in the some kind of prize removal by Elon Musk. So that's pretty dope. Don't really know what that's about, but awesome. They meet every other Thursday from 5 to 6 p.m. And the email is at the bottom. We can throw it up at the end of the meeting as well, if you guys are interested. So without further ado, I'm gonna pass it off to you. And we learned about some veterinary oncology.
Guys.
Oh.
The donation is still tied, so if you feel very strongly towards the orangutangs or the wild centers,
I don't.
go vote if you haven't already, and because anything you bought in regards to our merch and everything, some of your funding is going towards that, so if you feel really strongly. So it's either of those two things, or maybe a different one. Look at the two ones that we have right now. If you haven't voted, go vote.
All right, all good?
Yes.
My voice tends to project pretty well. Can anybody in the back like not hear me? All good? Okay. I tend to move around a lot when I'm talking, so I'm tied up here a little bit because I don't have a clicky. That's my own fault. But hello, welcome. Thank you for coming tonight. I was telling Kayla that this is a way better turnout than the pre-vet club I was in when I was an undergrad. We were like 7 people who would get together once a semester to go to the zoo or something. So you guys are doing great. My name is Rhonda Burge. I am one of the veterinary medical oncologists here at OSU. Out of curiosity, since this is a pre-vet club, how many people here are freshmen? Oh, a lot of you. Okay. The world is wide open to you. I love that. Sophomores? Okay. Few fewer. Okay. Juniors? Nice. Seniors? Oh my God. Okay. Well, that's awesome. There's a really good distribution. So, you guys are well on your way to having a lot of opportunities. I saw that carbon stick and ball thing on the thing, and I was like having organic chemistry flashbacks. So I don't do that very often for what that's worth, but presumably, how many of you guys have had an opportunity to do like shadowing or volunteering or working in vet clinics or with animals? So most of you are doing that. Great. You're doing a great job. So I know that everybody's probably at different levels as far as, you know, like what you've done, what your experience have been. So the goal for today is just basically learn about like what a veterinary oncologist does. Because I think at least if you're, I don't know if your parents are anything like mine, they're like, what, like dogs get treated for cancer, question mark, you know? So I still explain that to them every day what I do. So that's what I'm here to do for you guys. Out of curiosity, has anybody worked with a veterinary oncologist before? Cool. All right. Well, then we'll just go ahead and get started. Just to give you a little bit of my background, I am originally from Wisconsin. I grew up there, certainly around animals. I worked on a dairy farm, all of that good stuff, but always with dogs, as you can see in most of these pictures that I'm going to put up. I'm always holding an animal. So I was like one of those kids that was like, I want to be a vet from the time I was like 5 years old. But when I was going through high school, early college, like science and math were not like my strongest suits. I was much better at like history and English and whatnot. So I thought I couldn't go to vet school. I thought I couldn't get in. So when I was an undergrad, we did a lot of soul searching. I worked for a vet clinic for a long time. I went to undergrad at the University of Colorado Boulder. That's where that is. So if anybody's never been to Boulder, go at some point in your life. It's beautiful. And I worked at a vet clinic there for basically all 4 years of my undergrad and then a couple years after as I was trying to get into vet school. And so that was invaluable experience and I really appreciate it. I still love that clinic. I still talk to those vets. So just so you know, you can't always shake them even after you leave those places. And then I went to vet school at the University of Minnesota, which is outlined here. Did my 4 years there. The whole time I was in vet school, my plan was to go into general practice. I had no intention of specializing, but I did want to do an internship after vet school. Mostly to kind of like keep my options open and, get like a lot of strong mentorship by seeing a lot of cases very early. But then my plan was to go into general practice, maybe ER, something like that afterwards, because that was most of my background. I had been in ER and general practice clinics since I was 18 years old. And so I didn't know anything different. And then going through vet school and starting my internship, internships are really valuable, not only to solidify the things you love, but to kind of solidify the things you hate. And I was like, I hate surgery and I hate dentistry. So being a general practice vet probably wouldn't go well for me because that's like, I don't know, 70% of what you do, right? So I kind of rethought things during my internship and realized kind of what I was drawn most to were cases that were coming in of dogs and cats that had cancer or suspicions of cancer. I loved the workup of it. I loved talking to owners about it. I love the treatment options and really focusing on like quality of life for an animal. Whether we were treating palliatively to keep them comfortable for as long as possible, or we were doing surgery and radiation and chemo and all of those things. So luckily, I was still able to go from my internship to a residency. So I applied through the match, went to a residency at UC Davis in California. So I've been kind of all over the country, at least the West bit. Did my 3-year residency there. And then I joined Ohio State in 2020, deep in the heart of COVID, which I think we're not that, it's still around. Don't pretend it's not around, but at least we are well equipped, I guess, to deal with it at this point in time. So I have been here since then. I should also say, feel free to interrupt me if you can't hear me or I'm talking too fast. It's been known to happen before, so feel free to ask questions, anything you want. This is meant to be very like informal. So just as a little outline for kind of what I prepared to do today, kind of first of all is just what the heck does a veterinary medical oncologist do? What is their role in care of cancer patients, obviously, and what are kind of the branches of veterinary oncology that are utilized most commonly? I have a case example that we can work through. It does go through a lot of like blood work and imaging and things like that. And again, I know a lot of you probably have different levels of expertise in those things. So I'm not expecting you to tell me what does this dog's phosphorus mean, but just so that we can kind of get a sense of like a case that I would work with most every day and how I would work it up and try to get a diagnosis. And then basically what to do if you're interested in learning more about veterinary oncology. We'll kind of hit that at the end as well. So everybody here is probably well versed in this, but just in case anybody's interested, what is a veterinary oncologist? Obviously, it's a veterinarian who has undergone that. I got this from the web. I'm not saying that I have undergone extensive training. I have undergone training to become an in oncology, to obtain specialized knowledge to diagnose, stage, and develop treatment plans for pets with cancer. As a medical oncologist, I am somebody who often is kind of the front line for patients who are like highly suspicious to have cancer or have been diagnosed with cancer from their primary care veterinarian, and then they're referred to us for further workup. I'm kind of the person who will see them first, try to get a diagnosis, stage the patient, and then if we feel like they need surgery or radiation, I will get them set up to do those things with the surgical oncologist or a radiation oncologist. And if they need chemotherapy, then they come back to me for that. Questions about that? Beautiful. So there is always this joke that medical oncologists are kind of the air traffic controllers. Like you would come in and we go, okay, surgery first, and then come back here for chemo. You know, we do a lot of that. So a lot of communication, as you can imagine. So I guess kind of going backwards a little bit, I think the question becomes like, why do we care about cancer in pets? Like I said, my dad is still like, I would never treat a pet with cancer. I would never do the things that you do every day. And I'm like, that's great. Some people do. Over 1 million dogs are treated for cancer in the US every year. And 50% of dogs over age 10 will be diagnosed with cancer. This is a common disease process. We don't have as many good numbers in cats because dogs just readily present to their clinics more. And I think people are a little bit more willing to treat dogs compared to cats, at least depending where you are in the country. So most of the information is on dogs. But based on a nationwide insurance claim from those years, 2015 to 2021, purebred dogs are more likely to get cancer than mixed breed dogs. And I apologize if anybody in the room has these breeds of dogs. This is not meant to scare anybody, but boxers, golden retrievers, and beagles are most common offenders of getting cancer. I treated all 3 of those dogs in the clinic today. Like they're Also, we have to remember these are common dogs in the US. Golden retrievers are around every corner, right? Boxers and beagles also pretty common. So it makes sense that they have higher rates of cancer just because there's more of them walking around. It's also important for us oncologists to kind of know some of that information as far as breeds that like to get cancer, because some breeds of dogs are more likely to get cancer or certain forms of cancer than others. For example, Scottish Terriers, if anybody's ever known or had one of those, they're 21 times more likely to develop bladder tumors in their lifetime than a mixed breed dog. So if a Scottie walks in, has been having trouble urinating, has been having bloody urine, we're probably going to say, well, you should probably screen that dog for cancer because he might have cancer in his bladder, compared to a mixed breed dog where we'd say, oh, maybe it just has a UTI, things like that. So as you can imagine, there's a lot of different forms of cancer out there, right? We try to make it really simple when you're like a first, second year vet students to say, okay, all forms of cancer can be broken into one of three categories. You got epithelial tumors. Those are tumors that arise basically from the lining of, or the actual like tissue itself. You've got mesenchymal tumors. Those are things that arise from connective tissue. So things like bone, cartilage, blood vessels, those are mesenchymal tumors. And then you've got round cell tumors, of which there are about 5 or 6 types that are usually associated with the immune system, things like that. So really, all tumors can be categorized in one of those 3 categories. And similarly, like a lot of mesenchymal tumors will act fairly similarly. A lot of epithelial tumors will act fairly similarly. And it's kind of my job to know what those tumors most likely act like. Are they highly metastatic? Do they tend to go places other than where they grow? Do they, if they are going to spread, are they more likely to go to the lungs or the liver? And knowing that information can help us determine what the stage of the patient is. You guys heard about staging patients? Same thing as in human medicine. Basically, that means we're running diagnostics to say where in the body is affected by cancer. And so dogs or cats that present with cancer are going to have incredibly diverse clinical signs. It's going to depend entirely on what the tumor type is, where the tumor is affecting a dog or a cat. As an example of that, if you have a bone tumor in your jaw, you're probably going to have different clinical signs than a bone tumor in your leg, right? They might be the same cancer type, but they're probably going to present 4 different clinical signs. And so all of these clinical signs here are things that are fairly common for patients with cancer to present for. They can present for, sorry. They can be anything as vague as lethargy, maybe a fever, increased urination, difficulty urinating, a mass. An owner may just notice that, oh, a mass popped up on his elbow or his back, what have you. Limping, vomiting, diarrhea, not eating, weight loss, large lymph nodes, some sort of respiratory distress, or they can present in shock because they have blood loss from a bleeding tumor. So as you can imagine, there's not any one clinical sign that points to cancer. And cancer can also present basically with no clinical signs. So it's one of those kind of tricky things where there's a lot of non-cancerous disease processes that cause these same clinical signs. But for the most part, if you guys end up going to vet school and you go through 4th year and you're on clinic floor and a clinician looks at you and goes, okay, this dog has blank symptoms, what's a rule out for that? If you say cancer, you're going to be right like 90% of the time. Like cancer can present in many, many different ways. Questions about that so far? So just a little kind of background about, okay, when I have a patient come in and we have a suspicion of cancer for some reason, let's say the kind of the most common presentation, the dog grew a mass somewhere. There's a mass on its shoulder, something like that. How do we work it out? How do we prove that it's cancer, or how do we determine what type of cancer it is? Because I already said, you know, there's a bunch of different types of cancer out there, but knowing what type of cancer it is will help me know how best to treat it, where might it spread, how to stage it, things like that. So how do we go, you know, move forward and determine what type of cancer that is? Those of you that have had experience out in clinics before, have you guys seen vets that you've worked with do any sort of diagnostics to try to figure out if something's cancer or not? What have you guys seen, out of curiosity? Yeah.
Again, like an FNA or like blood work, like maybe.
Yeah, exactly. So things like this first one here is an FNA or a fine needle aspirate paired with cytology. So the needle aspirate is the actual act of taking a needle and putting it into a mass, switching it around a little bit. Your goal is to try to get some of the cells out of that mass put it on a slide, and then evaluate under a scope like this. And this is where I'm not a clinical pathologist. That's a different specialty. But as you can imagine, I look at a lot of cytology in my life. So it is something I feel pretty comfortable with. So I look at this and I go, oh, these look like round cells. You know, we talked about the 3 categories of cancer there. These look round. I can see that they're individualized. If I get down to round cell tumor, there's only like 5 options, easy peasy. And of the round cell tumors, this one looks most like mast cell tumor because I can see these little purple granules in the cytoplasm. And so I can, in a fair number of cancer types, especially round cell tumors, I can get a diagnosis with just the aspirate, which is awesome because it's cheap, it's fairly easy. Out in general practice, most of the time, you're going to submit that to a clinical pathologist to review. And so do I. I just have the advantage of like walking it downstairs and handing it to them versus, you know, mailing it and getting the results back in a few days. So this is a nice, cheap, easy way to at least get you to a point where you say, I'm worried this is cancer versus something else. And how to determine cancer versus other differentials for a mass on like a dog's leg could be things like an abscess or an infection, fungal infection, things like that. And so when we do this, if I see a lot of different types of cells, if I see neutrophils and plasma cells and all these other type of mixed cell population, that tells me it's much more likely to be inflammation in origin versus cancer, because cancer should be all one cell type. Cancer is some type of cell that is growing out of control and replicating from like one tumor or from one cell type. So you're going to have what's called a monomorphic population of that cell. Does that make sense? So this is like the cheapest, easiest way that we can often at least get a suspicion of cancer, if not diagnose the exact specific type. And to your point about blood work, there are some cancer types where we can diagnose them on blood work, things like leukemia or lymphoma. We can see the cells circulating in the blood. The hard part with trying to explain that to owners is that most cancer does not actually show up on blood work. You might get vague things, like you might get, you know, high liver values in a dog with a liver tumor, but there are also like, I don't know, 150 other differentials for a dog with high liver enzymes. So I wanted to jump immediately to cancer. But owners will ask, they'll be like, what's the blood type, or like, what's the blood test that I can do for cancer? And we're not quite there yet, unfortunately, but it is a part of workup for dogs with cancer a lot of the time. Sometimes, unfortunately, there are, oh no, what did I do? Oh man, well, at least there's still, there we go. Unfortunately, sometimes cancer, you know, the mass doesn't want to give up cells very easily. One of those tumor types that I talked about called mesenchymal tumors, they don't like to part with their cells very readily. And so when you do an aspirate on them, you might not always see the cancer cells there. And if they're not there, basically means that we need to get a bigger piece of the mass to evaluate. So that's when we think about doing things like biopsy and submitting for histopathology. And so you can see there are a bunch of different ways you can do biopsies, but this is essentially a small surgical excision of part of the tumor. That's really for diagnostic purposes only. I'm not trying to treat the mass. I'm trying to figure out what it is. Then you submit this to a pathologist. I'm not nearly as good at reading histopathology as I am at clinical pathology. So these are ones that you send out and you say, hey, what do you think that is? But this is the same tumor type as the aspirate I just showed you. This is also a mast cell tumor. Certainly histopathology is the gold standard of diagnosing cancer for almost any cancer that we have out there, compared to clinical or compared to like an aspirate and cytology. So this is what we'll turn to if we're having trouble getting a diagnosis with the FNA. All right, so those are kind of like my first steps for like a dog walking in, that the question is, there is a lump, what is that lump? Questions about that so far? Beautiful. So then the next step, once we figure out what that lump is staging the patient, determining where in the body is affected by whatever the cancer is. And so, like I've already kind of alluded to, different cancers will have different behaviors. And even sometimes different locations of the same cancer will have different behaviors. I gave the example a little bit earlier that you might have a dog with a bone tumor of its jaw. Most common bone tumor in dogs is called osteosarcoma. And if it's on the jaw, they actually have different behaviors than if it grows on the leg. So the leg, these are pretty aggressive tumors. We usually have to do things like amputate them and follow them with chemotherapy because they do grow, they're painful, but they also spread readily to the lungs. Jaw is a little bit different. They don't tend to spread as readily. So if we can control them locally with something like surgery, it still means removing part of the jaw, but we don't always have to follow with chemotherapy, and those dogs might live just as long. So kind of, like I say, that's part of my job, is knowing that information, keeping up with the literature to say, okay, there's this new study out that's looking at jaw osteosarcoma in dogs, and it looks like there may not be a benefit of chemotherapy compared to bone tumors of the leg, where we know there is a benefit of chemotherapy. Oh no. Oh no, we're doing great. Okay. So common staging tests that we perform, I think I've already alluded to some of these, but like your classmate here already told us, blood work is pretty common. We're going to look at things like white blood cell levels, liver, kidney values, protein levels. A big one for us is calcium. There are some tumor types that, for whatever reason, tend to increase the calcium in a dog or a cat's body. And that can be devastating to the kidneys. So if it does have a high calcium, I need to treat that tumor quickly, because it could actually put that dog into like kidney failure if we don't treat it rapidly. Chest x-rays, pretty common for most of the tumors that I treat. The lungs are one of the most common sites of spread for most tumors. And the reason here is that a bunch of blood pools into the lungs all of the time. And if you have tumor cells being spread via blood, they're going to get to the lungs eventually. So that's why it's probably one of the most common places for many tumors to spread. Not all, but many. Oftentimes we'll do some form of abdominal imaging. Many tumors will spread to places like liver, spleen, lymph nodes, and a lot of those are not things that I can palpate readily on an exam. I can palpate a few lymph nodes. I can feel the ones under the chin, in front of the shoulders, and behind the knees. And then if they're big, I can sometimes feel the ones kind of in the armpits and the groin area. But there's a lot of lymph nodes in the abdomen and in the chest that I can't feel just on my exam. Yes?
So do you almost always see something like on your exam first that leads you to like the abdominal imaging after? Or would there be any sort of like clinical signs that make you would think, okay, I need to do an ultrasound CT without feeling it?
Yeah, that's a great question. Did everybody hear that? Okay. Yeah. So it's probably a mix of both. If there are certain tumors, like dogs will sometimes get anal gland tumors, we know that the first place that those tumors like to spread is the lymph nodes in the abdomen. So even if I don't feel anything on my exam, if I know that dog has an anal gland tumor, I'm going to recommend looking in the belly, because it's going to change how I recommend treating that dog. Certainly, if I have a dog come in, let's say with a mast cell tumor, a lot of mast cell tumors are confined only to the skin, and they may not have spread anywhere. But if a dog with a mast cell tumor comes in and the owner tells me it's been vomiting and having diarrhea and not eating, I'm going to more highly recommend looking in the abdomen, because it's weird if it's either unrelated, like the dog happens to have a mast cell tumor and also, I don't know, ate a chocolate cake yesterday, which I have diagnosed before. Or it might mean that this tumor has actually spread to somewhere like the liver or the kidney, and I need to do an ultrasound to figure that out. Did that kind of answer your question? Yeah. Great. So it's a combination of both, really. We utilize ultrasound fairly commonly. Depending on the size of the patient and the type of tumor, we'll also do CT scans. So we do most of those tests almost every day. Again, we may choose one over the other for a variety of reasons. It might be money, it might be tumor type, or what we're trying to gain from it. If we're thinking of sending something to surgery, like let's say a dog with a liver tumor, having a CT scan is better for surgical planning. So we'll opt for a CT over an ultrasound in a lot of those cases. The image on the slide here is something called a PET scan. You guys heard of these before? It's a positive emission tomography, which basically is like a CT scan overlaid with basically me giving a drug into the vein that then lights up depending on how like metabolically active a tissue is. And we know that cancer is really metabolically active. It's constantly trying to take in nutrients and use like blood sugar, use glucose, because it's trying to grow and spread and change. So it has to use a lot of energy. So like the example here, all of these lit up areas, these are all cancer sites. And it's overlaid with a 3D CT scan. So I can tell you, oh, this dog, I believe this is a lymphoma patient, because I can see the red where a lot of metabolic activity is happening is located where the lymph nodes are. So under the chin, in front of the shoulders. It is a little bit silly because like the bladder was always going to light up, just because things are turning over and that's where the drug is. Liver, spleen, those are all locations where this dog's affected by lymphoma. And then if we repeat the testing after the dog started treatment, we can say, oh, look, a lot less lymphoma and almost no lymphoma. So again, these are like a PET scan is something that we don't actually have one here at OSU. We are getting one someday. But these are things that are being used more commonly in human medicine. And then usually vet med takes about 10 years to catch up. And so there are a lot of options for imaging, but most commonly are ultrasound and CT. And then I just said lymph node evaluation. Like I said, there's a lot of tumor types that will spread to lymph nodes. So it's really common for me to say, okay, this dog has a mast cell tumor here. The lymph node that if it was going to spread would probably be the one right here. Even if it feels normal, even if it measures normal, I'm going to take a cell sample the same way that I take one out of a mass. I just use a needle, get some cells out and make sure I don't see a bunch of mast cells in the lymph node. That would tell me that there's spread there. Questions about staging diagnostics? And I guess maybe it goes without saying, but the reason that staging these animals is so important is generally it's going to affect the prognosis of the animal. Depending on the tumor type, the higher the stage, the further it has spread from the primary tumor, probably the worse prognosis. It's also going to change what I do. Going back to that example of a dog with like an anal gland tumor, if it hasn't spread anywhere, if there's no lymph node enlargement, the lungs look good, I can send that dog to surgery, have the tumor removed, and that dog might live 5-6 years without any problems. If I don't look in the abdomen and there has been spread to the lymph nodes, I still have treatment options for that dog, but now it means that I have to go back to surgery to remove the lymph nodes from the belly, and the prognosis is probably going to be different. We might talk about chemotherapy afterwards, and that is going to affect what an owner wants to do. So staging at the time of diagnosis really helps us both from like an owner standpoint and a patient standpoint. And then like I alluded to before, there are kind of 3 broad categories of treatment modalities when it comes to treating cancer. I am lucky enough here at Ohio State, we have an integrated oncology service, and that means that we have medical oncologists, surgical oncologists, and radiation oncologists, and we all work out of like the same room. We all work together, we see the same patients, and it's a really nice system because I come from where I did my residency. We had surgical oncologists, we had radiation oncologists, but they were in kind of like separate areas of the hospital. We'd have to try to come together like once a week to talk about cases. Today, or like here, I talk about cases with those people every day, twice a day, at least, if not more. So we're really lucky here. It's not something that you find everywhere. But realistically, probably only one of these modalities is very good at curing cancer, and that's surgery. So if you're into like the cure game, become a surgeon. And they'll happily tell you that they cure cancer, and I just make things live for hopefully a long time, but maybe don't cure things. Chemotherapy and immunotherapy, I'm kind of lumping those together, but those are systemic therapies, and that's what I do for the most part. And then there's radiation therapy. So radiation therapy and surgery, they're mostly aimed at treating the primary tumor. So they're trying to treat local disease, whereas what I do most of the time is I'm trying to prevent or slow down the spread of disease. Questions about that? So as you can imagine, we've already talked about how diverse cancer is in how it presents, patients that it affects. You know, in general, we think about cancer in people, but also in dogs and cats as affecting mostly older individuals. And that's true. Probably the average age of the patients I see is probably about 8 years old. But unfortunately, cancer can affect even younger animals. The youngest dog I've ever treated for cancer was probably like 8 months old, 9 months old. And, you know, they're not always bad, but it's not great when you get cancer when you're that young. All of the treatments are going to be personalized for each patient, and it's going to depend on a number of factors. And I've listed some of them out here, but there are tumor factors that we need to take into account. Like I said, are they likely to spread? Are they less likely to spread? What do they respond best to? The grade and the stage, all of that is going to fall under tumor factors. There are also patient factors. Do they have comorbidities? Is it an 18-year-old schnauzer that also has diabetes and Cushing's and kidney disease, and now you want me to give that dog chemotherapy, it's probably not going to go great. Or are they otherwise a pretty healthy dog? Things like temperament have to be taken into account as well. A lot of the patients I see, they come in weekly or every other week for chemotherapy. And so if that's miserable to that dog, it's probably not fair to put them through a treatment like that. So we might choose a different protocol for that dog, not because another one wouldn't necessarily be better, or they might respond better to it, but we have to keep their quality of life in, like, that's the number one thing, no matter what I choose to treat them with, right? And then there's going to be owner factors. We've got those pesky owners that have expectations and they want things for their pet as well. Their expectations, cost of treatment. Unfortunately, I can't give away these things for free. Ability to travel to appointments. We have patients that come from Michigan and West Virginia. And if I'm telling them to come in weekly, could you drive 6 hours weekly to bring your pet somewhere? I couldn't. I would love to, but I couldn't. So again, sometimes we make adjustments in protocols simply for those reasons. And that's not bad. It's a good thing. These are owners who are dedicated and want to do things for their pets. So we have to try to take all of these factors and figure out the best protocol and the best plan for each patient. Okay, that's kind of like a little bit of a background of like medical oncology and what I do on a daily basis as far as diagnosing, staging, determining tumor types. Any questions about that before we start like a little case scenario? This meeting goes till 8, right? Okay, just making sure. I don't want to keep you longer than you need to be here. I know you're busy. So like I say, I'm not expecting you guys to be able to look at blood work and analyze it and figure out like what's going on, but I just figured we'd work through a case that would be something, at least an interesting case to me, and kind of see if it's something you guys are even interested in. So this is a very cute dog. This is Patches. He's a 12-year-old male neutered mixed breed dog who presented to us. Basically, he presented through our ER service for increased thirst and urination, also called polyuria and polydipsia. On physical exam, I know that that's very small writing, but I can basically tell you there were not very many changes. The only thing that really jumped out at the clinician who first did an exam on this dog is that he had diffuse hypertrichosis or hair loss kind of along his trunk. That was really the only major change. Other things were just like kind of associated with age, a little tartar on his teeth, things like that. But everything else was pretty normal on his exam. And so anytime a patient comes in, no matter if you're seeing an oncologist, an ER doctor, a general practice doctor, especially as you're starting vet school and working through scenarios like this, people love to have you make a problem list. You got to make a problem list for every problem that that dog has. So in this particular case, there's only 2 things that we know about Patches so far. We know he has PUPD and we know he has hypertrichosis. So when we make a problem list, then we need to make a differential list and a plan associated with each problem. People will do different things as far as like, are you a lumper or do you like to keep things very separate? I tend to be a lumper, but in this case, I don't know if I can relate the PUPD and hypertrichosis together. So right now they're 2 separate problems. So then I think, okay, well, what are differentials for these things? Anybody have any, well, I guess before I go to it, anybody have any thoughts about a dog who's presenting for increased thirst and urination? Yeah. Diabetes, absolutely. Endocrine disorders in general, but diabetes is a huge one. Absolutely. Any other thoughts? Yeah. A UTI, absolutely. If we're losing more urine because we're just peeing more because it doesn't feel good and you got to pee more, you might drink more to compensate for that. So it's certainly things like a UTI. So these are, you're already halfway to being a vet, you guys. You're doing great. In general, I tend to separate this out into kidney versus not kidney. So there are a lot of not kidney reasons that a dog may be PUPD. Endocrine disorders like diabetes is definitely one of them. Things like increased calcium, liver disease, and then there's something called psychogenic polydipsia, which we're not going to get into, but it basically means your brain tells you to drink even when you don't need to. And then there's kidney. So you can have an acute kidney injury or you can have chronic kidney disease, both of which make you drink and pee more. And then for hypertrichosis, I don't want to focus on this too much, but is it a primary skin disease or is it secondary to something? Endocrinopathies like diabetes can cause hair loss or hair changes. Or you can have things like, it could be as simple as the dog has fleas. So there's a lot of different options there. So then I take a look at those differentials and I say, okay, what kind of plan could I put in place to try to rule in or rule out some of these differentials? So for an example, if I'm trying to say, okay, this dog's PUPD, it might have diabetes, what kind of diagnostic test would I do to rule in or rule out diabetes? Anybody know? Yeah, do some blood work. Look at what the glucose is. If the glucose is 700, that dog's diabetic, right? So kind of thinking along those lines. I said to the owner, well, I think that we should probably do a CBC, chemistry, urinalysis, and a culture to rule out something like a UTI. A thyroid panel would be nice because dogs with hyperthyroidism can drink and pee more. And then other endocrine disorders we could rule in or rule out with something like a baseline cortisol. Don't get too wrapped up if you're like, I don't know what all those tests are. That's totally fine. This is just kind of an example of how we would work through a case together. So in this scenario, we moved forward with a CBC, which is a blood test looking at your red blood cells, your white blood cells, and your platelets. Here, I'm mostly focusing on, does the animal look like it has any evidence of like infection? Like, could a urinary tract infection show up on blood work? Fairly rare, but if it was really bad, it could. Honestly, I know there's some red and some blue on here, but for the purposes of this discussion, this is pretty normal. We're not having anything to like really jump out at us to explain why this dog is PUPD. All right, so we move on. We do a chemistry. All right, so BUN and creatinine, those are both kidney values. So these are both normal. So that's telling me that his kidneys are working pretty appropriately. So all of those things that I said kidney was a possibility for, I can pretty much rule those out with normal kidney values in this dog. So that leaves us with not kidney things. So then I'm looking at the rest. He has a little elevation in one of our liver values. Don't worry about these too much. They're only very mild changes, so I'm not going to worry about them. His calcium is a bit high, however. The high normal for a dog is 11.5. His is 17.2. That's pretty significant. So we've got hypercalcemia and maybe some changes to a liver value. Okay. Here's a urinalysis. Again, for the purposes of this conversation, we're not seeing any bacteria. We're not even seeing very many white blood cells. There's no evidence of a UTI here. One thing I do want to pay attention to, when an owner tells me that their dog is having increased thirst and increased urination, I want to look at something called the specific gravity, which is basically determining how concentrated the urine is. If this number is high, meaning if it's very concentrated and very yellow urine, this dog is not drinking more than it's supposed to. Like, then I would have to say to an owner, are we sure this is the dog who's drinking more, or did you take water away so he couldn't drink or urinate for the past 24 hours or something like that? Because if it's a high number, I can tell you that he is concentrating appropriately, and I shouldn't see that in a dog who's drinking a ton. Does that make sense? Perfect. In this particular case, this is a fairly low number. This is confirming to me that this dog probably is drinking a lot of water. We did a urine culture. Nothing grew on it, even though we didn't expect it to. So that's great. We don't have a UTI. We did a thyroid panel. In general, it's a little bit low, but that doesn't really fit with anything else we've got going on. I need to keep it in the back of my head, but I'm not super worried about it. And so most likely, based on the workup that we've done so far, the thing that I can associate with PUPD thus far, most likely is going to be the hypercalcemia. We have a couple other problems to add to our list now. We've got that liver value that's elevated, and we've got kind of low T4 value, which is a thyroid level, but I'm not going to have us go through all of those. The big kind of points to take away here is the PUPD. So then we need to make differentials for that hypercalcemia. So we've got an increased calcium and a low phosphorus. So certainly cancer is going to be on the list for animals with hypercalcemia. I think I said a little bit earlier that there are certain types of tumors that are more likely to cause hypercalcemia compared to others, but in an older animal, it certainly has to be one of the things that we think about. There are other disorders out there that can cause high calcium. Things like, well, your parathyroid is what controls calcium in the body. So if your parathyroid has some sort of disease, that could cause it. You can have toxins and other lesions that can cause it. But again, to make things simple, this is probably either cancer or the thyroid or the parathyroid that's affected. So then how do I try to determine, one, if this dog has cancer, where is it? Because I didn't find anything on my physical exam. And two, how do we evaluate whether a parathyroid is working properly? So for those things, there are 3 common tumor types that cause increased calcium in dogs. One is lymphoma, One is the anal gland tumor we were talking about a little bit earlier. And then there are a multitude of others. Certainly lymphoma and anal gland carcinoma are the top two. And then there are things like thymus tumors, multiple myeloma, certain carcinomas. Again, it's my job to know which ones are most likely to do it. But I want to try to focus on looking at places in the dog's body that are most likely to cause what's called a hypercalcemia of malignancy. So if I think this dog might have lymphoma, I should probably pay special attention to his lymph nodes. Go back and feel them. Do they feel big? Do they feel firm? Or look at lymph nodes that are inside of the body. They don't have to be just outside of the body. We can have lymph nodes in the chest. We can have lymph nodes in the abdomen. So maybe I need to look further into those lymph nodes. And then if we didn't do a rectal exam, which sometimes we don't when they come in through ER because we have bigger fish to fry, totally fine. We should go back and make sure we don't have a mass in the anal gland. So I have that there under the plan. We want to do a rectal exam, lymph node palpation, chest x-ray, ultrasound, things like that. So this time we went back and did a rectal exam just to make sure we weren't missing anything. We expressed his anal glands because if they have, material in their anal glands, if any of you who have worked at clinics know that some dogs are coming in and you've got to express that material for them because they don't do it on their own. If those are really big, I can't tell you if there's a small mass hiding in there or not, so I have to express them and really feel. This dog, his anal glands expressed easily, no mass is present, so I think an anal gland tumor is fairly unlikely. So then we did some chest x-rays. I don't know how many of you guys are comfortable looking at and interpreting chest x-rays, so I've got kind of a normal view here with normal things labeled. So you've got your heart, your lungs, stomach, liver, trachea. And so this is Patch's chest x-ray. So would anybody like to be brave and volunteer and say, like, compared to a normal chest x-ray, is there anything abnormal over here? You'll never be wrong. I won't yell at you, I promise. Yeah. Yeah, there's definitely something. If this is supposed to be black lung, over here, this is not black lung. There's something going on. So there's some sort of soft tissue there that shouldn't be there. And so this is him laying on his back. Again, we've got heart, we've got lungs, and we can see this should be black. This should be lung over here. And there's something soft tissue instead of lung. Question about that? Beautiful. For the purpose of this, he had an abdominal ultrasound. There were really no abnormalities. His lymph nodes were totally normal. No big findings there. So now I know that I have a dog with a hypercalcemia and a cranial mediastinal mass. So that's what that area in the chest is called, is the mediastinum, kind of in this general region here. That's where a lot of blood vessels go through. There's some lymph nodes in that area. Thymus lives there when you're a young puppy. Usually when you grow up, you don't need a thymus anymore. So it kind of shrinks away into nothing, but that lives there too. And so I can kind of rule out Agasaka or the anal gland tumor at this point because we didn't find evidence of that. There's no spread, obviously, into the abdomen. So I don't think that's what's causing the hypercalcemia. But this craniomediastinal mass might be. We could still have lymphoma on the list, but we can also have things like thymomas. So that's a cancer of the thymus. So I said, even though in most dogs, as they get older, that shrinks away. In some dogs, they do become cancerous and then they grow out of control. And those can also cause hypercalcemia. And so really to try to determine what this mass is, we have to sample it, just like what I was talking about at the beginning of the lecture with either a needle or going in and getting a biopsy. We can pass needles into the chest. I know it sounds scary, but if you're going to pass something into the chest to sample, we can do that generally fairly safely. There's actually fairly low complications with that procedure as long as we do so safely. And so that's what we did here. He actually had a CT scan. Again, this is the heart, lungs, and then there's this giant mass that shouldn't be there. So there's him on his back, giant mass that shouldn't be there. So this is a sample that we got for cytology. These are the cells. And I'm not expecting anybody to look at that and be like, oh yeah, cancer. But one thing to take away is that a lot of these cells all look pretty similar to one another. Just like what we talked about earlier, it's not like there's a bunch of bacteria or inflammatory cells. Like these all kind of look like one population of cells. So then we submit that to a clinical pathologist who looks at it closer. And they determine, are these epithelial cells? Are they round cells? But they actually said this looks most consistent with a thymoma. So this is a type of benign tumor that arises from the cells of the thymus gland. These are fairly rare tumors. I picked kind of a weird one for this discussion just because the imaging is so cool on this dog. And actually, we do know that these tumors, not only can they cause hypercalcemia, but they can cause other what's called neoplastic syndromes, meaning clinical signs not associated with the tumor itself, but the tumor causes it. So like the hair loss was from the tumor. It affects, I don't know, hormones or something like that, that affects hair growth. And so he actually lost his hair because he had that tumor there. A lot of different ways that we can treat this. The gold standard would be surgical excision. You actually send this to a surgical oncologist or a very well-trained surgeon. They actually, go into the chest, remove the affected thymus, stitch them back up. I'm making it sound really easy. I would never do it, but somebody will. And honestly, with a thymoma, because it's a benign tumor, they can survive the rest of their life and do quite well. It's unlikely for that tumor to spread or cause other problems. So that's kind of the gold standard. But if I can understand, maybe in an older dog that has a lot of other comorbidities, you're not like itching to do a surgery to go into a dog's chest. We can also do radiation or palliative care with things like steroids. They're just probably not going to keep the dog comfortable as long as surgery does. So Patches went to surgery. Look at him. This is him post-surgery. Look at how good that looks. No more tumor. And he's been coming on to see us like every 3 months for a couple of years now. And it's never grown back. He's doing great. His hair grew back. He looks amazing. All right, so I know that was like a whirlwind of like how you work up a case, but that's kind of like what I do for every patient that comes in as far as what do I know? What do I need to know? How do I figure out that information? Questions about that? Okay. All right, I think we're doing okay on time because I want to leave time for questions too. But realistically, if you are interested in learning more about oncology, it is a fairly niche category. I totally get that. And most people aren't going to be exposed to it until they go to vet school or unless you happen to work at a specialty clinic that has an oncologist there. But certainly, we're lucky in this area. Not only are there oncologists at OSU, but there are private practice oncologists in Columbus and Cincinnati and Cleveland. If you wanted to learn more or see what they did on a daily basis, see if you could shadow, see if you can hang out with them for a couple of days over spring break, something like that. So just see what that life is all about. If you work with a veterinarian currently, ask about their experience with oncology. There are a lot of good private practice general practitioners who do some level of cancer care. Maybe they take mast cell tumors off all the time. Maybe they offer chemotherapy. Ask them what their experiences are and what they like and what they don't like about it. If you were interested in becoming an oncologist, you get to do all of the cool stuff that we just talked about, but you also have to have like a true love for things like basic science and immunology, because there's a lot of like really intricate science about like chemotherapy and what it affects and what it's targeting. And as we're learning more, we're using a lot more immunotherapy. So you need to know immunology pretty well. And then you have to love client communication. These are a lot of times animals, especially for me, a medical oncologist, I'm going to be seeing their pet weekly or every other week, sometimes for like 6 months at a time. And then hopefully if they do really well for years thereafter. So you have to get really good at sometimes giving bad news, which sucks, but we're all going to do it. And you get good at it at some point. And then just kind of like talking owners through kind of big, scary moments in their life, right? Nobody wants to come see an oncologist. And that's how I always enter a room. I'm like, I am sorry you're here. No one wants to talk to me. I totally get that, but let's make a plan. And usually that works out fairly well. Okay, I got to the end. I talked really fast. This is my dog. He's really cute. He doesn't have cancer yet. He probably will someday. Okay. What questions can I answer for anybody? Thanks for your attention. I really appreciate it.
What was kind of the turning point in your career when you decided that oncology was something you wanted to seriously?
What was the turning point in my career when I really wanted to like know that I wanted to pursue oncology? I'd say probably during my internship. Like I said, I kind of went into my internship knowing, like thinking I wanted to do GP or ER afterwards. The more exposure I got to those patients, one, I just love old dogs. Old dogs are the best. And so being an oncologist, you get to see a lot of old dogs, which is great. And then I just found myself really being drawn to those cases that are coming in where cancer was like a top differential. So they came in with a big anal gland mass or big lymph nodes. I wanted to stick with those patients and like continue working them up and see kind of what the owners chose to do and how we could treat it. I just found myself, I kept going back to those cases. And then I spent some time with the oncologist at the clinic that I did my internship at, and that kind of probably solidified it. Yeah.
Just assuming because you do work in oncology, how do you handle the tough cases and the losses? Cause I just. I don't know, I love immunology and research and everything like that. But I
Yeah.
just don't know if I can handle.
Yeah.
People see.
Yeah. That's a great point. And you know what? I don't know if any of you guys are friends, with any of the, oh man, with any of the fourth year, veterinary students or any of the current vet students. Because a lot of vet students do come to the oncology rotation really scared that it's gonna be constantly sad. And you're right, we do have some sad days, we do lose patients, but so does every other service in this hospital, right? I actually think, to be perfectly honest, I tend to think that ER and GP has the harder job because they're usually the ones diagnosing the cancer. They're the ones giving the hard news to an owner saying, I am worried that your dog has cancer, or I've diagnosed your dog with cancer. Here's some information. I recommend you go see an oncologist. I think that moment is much harder than when you've had some time to kind of digest that information and then you go into like work mode. Like, what are our options? Tell me more about this and what can we do to try and help? And I think because, you know, my job every day is to give a dog the best quality of life possible for the remaining time that dog has left with its family. That's really rewarding. Not every dog has to do chemotherapy. Not every dog has to do radiation therapy. We can provide a lot of care. Maybe it's a steroid alone. Maybe it's pain medications to help that animal feel better. So even if we help them feel better for 3 months, I would rather do that than have them feel miserable for 2 years, right? So most owners, when they walk away, even if they end up losing their animal at the end of a long, hard fight, most owners are really happy that they did it. And most owners are really appreciative of the time that they had left. So yeah, there are some hard days, but it's way more rewarding than it is hard, personally. Great question. Yeah.
Do you only see cats and dogs, or do you see anything a little bit weirder than that?
That's a great question. At OSU, we don't have an exotic service here. So I don't see any exotics here. Where I did my residency, there was an exotic service, and every once in a while they'd be like, hey, can you give this parrot chemo? And I'd be like, I guess. Not knowing exactly what it was gonna do. Occasionally we'll get referrals to like give some information about horses and things like that. But in general, the vast majority of cases that we see are cats and dogs. If you want to do weirder things, there are people who will come find you for those weirder things for sure. Ferrets and rabbits get a decent amount of cancer, so occasionally we'll talk about those, but they don't come to OSU very often. Any other questions? Yeah.
So thinking about like zoo med in particular, that's a lot of like preventative medicine, and there's a lot of like older patients because they live longer in captivity.
Yeah.
So do you ever see like an intersection of that field with oncology?
Yeah, I treated a tiger for kidney lymphoma at one point in time. Again, once things start getting into zoo animal medicine, that's a lot of politics. Like, is it fair to try to put this animal through something like chemotherapy? Is it, you know, I hate to be that person, but like, is it valuable to the institution or, you know, what have you? And ultimately, I don't get a lot of say in that. That's all from their end of things. So to me, it's not as rewarding because I'm like, oh, I could do more, but they tell me I can't. So, you know, and obviously, it's a big toll on like darting a tiger every week to give it chemotherapy. You have to do something a little bit more realistic. So, there are intersections, but how much we actually end up treating those, it's kind of like cows get cancer, but we never treat them because they just cull them, you know what I mean? Any other questions? Yeah.
Can you tell me those knowledge charts every patient you have, like after the meeting with the patient, like you go back and like, okay, I'm gonna write this down. Is that usually your process?
Yeah, that's a great question. So, admittedly, the longer you do this and the, like, because I have such a niche field, I need to keep all those things in mind. Do I like write them down every time for myself? No, you know, I kind of go through the more common things. It's very common for us to say, okay, we're staging this patient for probable cancer, chest x-rays, abdominal ultrasound, CBC, CAM-UA. Those are the things I want if I can do everything. So it's an exercise, I think, especially when you're a very new veterinarian, it helps you not overlook a problem that would maybe be overlooked if you didn't write it down. So we actually do have our veterinary students who are on the rotation with us. We often have them take like one of their cases for that day, and that's how they work it up. They're the ones who tell us, okay, what are your problems? What kind of differentials do you have for those problems, and what plan do you have for those problems? So I do think it's important to do probably at all stages in your career, but especially when you're newer and still learning.
This is kind of specific, but when you're doing your analysis, are you doing free catch or cysto, or does it matter?
It's a great question. Depends on the problem. If the dog has a bladder mass, I probably don't want to put a needle into the bladder because I could do irreparable damage. Like I could do what's called seeding. So the cancer cells can hold onto the needle, and then as you pull out, those cancer cells can go along the needle track, and then they can grow along that needle track. And that might be life limiting for the dog at some point. But if I think the dog has a urinary tract infection, I'd rather have a cysto than a free catch. So it depends on the situation. I do both.
You say staying and neutering your pets decreases the likelihood of cancer?
That is a great question. Does staying and neutering your pets decrease the risk of cancer? So it's a simple question with a lot of complexity to it. Anybody here have like a giant breed dog? Or have worked with giant breed dogs? If you had to spay or neuter them at some point in time, did you have a discussion with your vet of like what the timing to do that should be? Because with those dogs, in general, we're recommending at this point in time, especially males, females are a little bit more complicated, but that we wait till they're skeletally mature. Because we do know that dogs, especially large breed dogs or dogs that grow like up quickly, have higher rates of bone cancer if they are neutered too early in life. But dogs, female dogs, if we wait to spay them, they have higher rates of mammary tumors and uterine cancers and things like that. So it's a balance. There's no one right answer out there. And so it's really an education game at the time. But in general, spaying and neutering does decrease the risk of some tumors. It potentially increases the risk of others because you're impacting hormonal changes in that animal for the rest of its life. Now, all that being said, the data can be really hard to interpret because an owner who spayed or neutered their dog when it was 12 weeks old is probably a pretty good dedicated owner who's going to keep bringing their dog in regularly and routinely. We get more data to track. And when it dies, we figured out what it died from versus an owner who waited 3 years. It lives in the backyard. It doesn't get any heartworm, flea, tick medication, never got vaccines, and then it dies suddenly one day. So like, did that dog not get cancer because it wasn't neutered, or did we just not diagnose cancer because nobody brought it anywhere? Does that make sense? So it's a great question. I think it's really individualized for the dog, the owner, and like the type of lifestyle it's gonna live.
Going back to patches, was the low T4 related to the thymoma or is it unrelated?
That's a great question. In general, it wasn't related to the thymoma specifically, but when dogs are systemically ill for any reason, it can cause their thyroid levels to go down. So once he was treated for that, his thyroid went back up to fairly normal levels. So it wasn't the fact that it was a thymoma, it was just that he was systemically unwell. Does that make sense? Yeah, great question. Anything else?
How long did it take you from that whole work?
We did that all in one day. I shouldn't say that. Maybe we did most of it except the CT. We did all of the blood work, the blood work, the aspirate. We did all of that in one day. We probably did a CT the next day and he got surgery within a week. Anything else? Yeah.
Sorry.
No, I love it.
Where are you sending that, this for this dog?
Again, luckily, because I'm at OSU, we have histopathologists on site. Occasionally we will send them out if we have like a specific question for somebody that has a specialization in like dermatologic cancers or something like that, but generally we have the pathologist here on site that we send them to, meaning that we put them in formalin, fill out a short form, and then walk them across the street and say, here you go, fix it, please, thank you.
Cases do come. Like, is it 1 or 2 or is it like 10?
Me, myself, and I alone, or like the service?
Just you as an individual.
So as a faculty, it really depends on the day. Obviously, because we're training residents and interns, we want them to see the majority of the cases because they're learning and we kind of oversee them. The medical oncology service as a whole will have usually 4 to 6 clinicians on, and we'll see anywhere between, probably 18 to 25 cases a day. So 15 to 25 cases a day. How many I am personally working up and seeing, it can range from 0 to 3, because I also have to like approve chemo for everybody and like keep track of everybody's cases, so I've got to be like readily available to help as well as see my own cases. And then sometimes a lot of clinical trials patients come in as well, and usually faculty are responsible for overseeing them. I would say out in like private practice where you're not training others and you're just kind of seeing your own cases, if you're a single oncologist working alone with a couple technicians, probably gonna see somewhere between 2 and 4 new cases, and then anywhere between 5 and 10 recheck chemotherapies, those kind of things in a day.
What would you recommend them?
When would you recommend an animal for a clinical trial? That's a great question. Probably not with an easy answer, but I would say in general, when we're talking about cancer clinical trials, it generally is if they failed gold standard of medicine. So let's say we've given them chemotherapy and their disease has progressed, and we don't have like a great second option, an investigational drug may be a good option for them. If owners are looking to try something different, like they don't actually have very good options to start with, or they cannot sometimes get funding to be treated. If an owner comes in and they don't have a lot of money to put towards care for their animal, by enrolling in a clinical trial, their care might get paid for. It might not be gold standard, but it may benefit their patient. And sometimes clinical trials are as simple as, hey, we'll pay for this CT scan before you take your dog to surgery for a liver mass. So that we can investigate what they look like on CT. So it provides a little something to the owner, an incentive for them to do a test that we want them to do before they go to surgery. So there can be a lot of different scenarios, but that's a great question. Cool. Well, I'll hang around a few more minutes. If anybody has any more like individual questions, I'm happy to chat. You guys are a great audience. Thanks for being here. And what day is it? Wednesday? Thanks for being here.
Thank you so much.
Oh,
That was
yeah,
fantastic.
thanks for inviting me.
Yeah,
I really appreciate it.
absolutely. Yeah, I feel like that was freaking awesome. Alright, thank you. I know there's a lot of safety.
I know, there's a ton. You know, it was one of those scenarios where I was like, I want it to be really